Hey everyone, it's Megan Rinkus. I'm presenting on chapters 8 and 9 this week. I also have a cold, maybe have more of a voice than Callie did last week, but we will power through. Chapter 8 goes over diagnostic and screening tests with the chapter objectives of differentiating between the two, calculating sensitivity and specificity rates, differentiating types of reliability measures, and differentiating validity and reliability. So starting with screening versus diagnostic testing. Screening testing is when you are testing in an asymptomatic population for the presence of a disease or health condition. It can also be presumptive identification in the population by the application of a test or exam. And then patients who do have a positive screening test will undergo further testing for a confirmative diagnosis. Some examples of this would be like blood pressure measurements, skin assessments, screening for like melanoma, blood glucose tests, more of like just an isolated fasting glucose test or random. And then also mammograms can either be screening or diagnostic. So if it's just a yearly screening, you would actually code that under screening. However, if you were to find a lump or the patient was to come in with a concern, you would code that under a diagnostic mammogram. So you do have a couple of cases where they can be both. And then screening tests can also be used for a mass population, and that's called mass screening. So they used that a lot in the COVID-19 pandemic, and really to identify and screen the most high-risk patients. So diagnostic testing is conducted on a patient with the intent of confirming the presence or absence of a disease in a symptomatic individual. So I kind of gave an example about the mammogram, but also, if somebody came in with, kind of looking like diabetes, you could do an A1C, and that would be more towards the diagnostic route. So this is when the differential diagnoses come into play, and we would use diagnostic screening to quote unquote test our differential diagnoses. An example that came to mind was recently used in clinic. We were ruling out either prolonged mastitis or inflammatory breast cancer, so the patient went to get a diagnostic mammogram, and luckily it was just some mastitis that wouldn't go away, but that would be an example of that. So validity, sensitivity, and specificity all go hand in hand. Sensitivity and specificity are like subcategories of validity. So validity is the ability to detect the disease that was meant to be measured, distinguishing between those who do and do not have the disease. So a valid test has the ability to detect the disease that it is meant to measure. And then the subcategory of that sensitivity would be the sensitivity of a test is the ability to correctly identify those individuals with the disease. And specificity would be the test's ability to correctly identify those who do not have the disease. So they're really just the opposite of each other. And a test with 90% sensitivity means that 90% of the individuals screened by that test will have a true positive, meaning that 10% will have a false negative result. Again, I know I give a lot of women's health examples. That's just kind of my thing, but I think of all of the genetic testing that we offer moms while they're pregnant. You want to make sure that they have a high sensitivity rate. If we are identifying that the baby has Down syndrome, that's a pretty big deal if we're telling these patients that they came back positive for that and it, maybe they weren't, or vice versa. A lot of times that's missed too. So it's important to calculate both sensitivity, which again are really the true positives. You would take true positives and divide that by the true positive plus false negatives, and then times that by 100, and that would give you your sensitivity rate. And then specificity, which is the proportion of the true negatives, is really just doing the opposite. So it's the true negatives and dividing that by true negatives plus false positives, and then timesing all of that by 100, and that'll give you your answer. So I know the slide says reliability, but before we get to that, I wanted to talk about the positive predictive value and negative predictive value, as that goes hand in hand with the sensitivity. So the positive predictive value really has the same goal as measuring sensitivity, but at a population measurement and not so much focusing on individual. So it's the proportion of those individuals who tested positive who have the disease among the population screened. So the higher the prevalence of a disease, the higher the positive predictive value. And that's calculated just a little different as true positives. Divide that by true positives plus false positives, and then times that all by 100, and that's what would give you your percentage. And then on the end of that, other end of that would be the negative predictive value. And that tests the proportion of individuals of those screened who test negative, who do not have the disease. So this information is typically used to educate and counsel the patients and community regarding the performance of the test and measuring the presence of disease or health condition at the individual level, and how well that test really performs at the population level. So now that we've covered both of those, I would like to jump into reliability. So we know that it is the consistency with which a test accurately measures a characteristic over time. So variation in test administration and interpretation can really negatively impact the result of a test. The percent agreement is the inter-observer agreement, and that can impact the reliability of a test. And percent agreement is a measure of reliability among multiple observers. So then the kappa statistic test is used to evaluate the inter-observer reliability. And it measures the extent to which the observed agreement exceeds the expected agreement by chance alone. Excuse me, sorry. And the kappa statistic formula is in our book on page 102, all the way at the bottom. So I've provided a graph here with just some of the types of reliability. It doesn't cover all of them. Table 8.4 in our book on page 104 has a couple more, but I just wanted to kind of present the most common types of reliability that are used. And then to wrap up this chapter, I just wanted to kind of touch base on, okay, well, why does this matter? Why does this matter as nurse practitioners and healthcare professionals? As I mentioned earlier, we do need to know what's screening versus diagnostic and how to code that. But we also really need to know the statistics of the reliability and the validity and the, sensitivity rates of the tests that we are ordering, so we can properly educate our patients and what happens if we get a false positive or a false negative and how that impacts their plan of care. So I think it's very important to know those numbers as you can properly educate your patients as a result of that. So chapter 9 was the risk assessment and estimation chapter, and our objectives are listed below. So it's describe the steps of the risk assessment, and then really it was just a lot of calculations in this chapter. I'll hopefully go through this a little quicker. just because I did list a couple calculations, but really it's easier to look some of the longer ones up in your book. So the way I look at this, we undergo risk assessment every day, even if we think of it or not. I just think about from the time I open my eyes, I have to calculate a risk assessment of me laying in bed an extra 10 minutes, and how is that going to put me behind? And, can we swing it? Can I get my daughter ready in enough time? So I know that's a very minuscule, personal level of a risk assessment, but I feel like we go through risk assessments in our personal life every day, but this obviously is more towards like the epidemiology side of things. So the common risk factors that are book listed, which are really just a refresher, are the biologics, so that's non-modifiable, like our race, age, ethnicity, stuff like that. Lifestyle being the biggest modifiable risk factor. We do so much education on this in the clinic, and I'm sure you guys are all doing the same, like BMI, smoking, drinking, risk-taking behaviors. And then the last two are stressors and environmental. I feel like these can swing back and forth on whether they're modifiable or not, like your job, your living situation. But non-modifiable would be like air quality and water quality. So the risk assessment is really a tool that attempts to determine the risk factors and magnitude of a risk that exists. So it attempts to characterize the nature and magnitude of health to risks to humans associated with a risk agent. So most risk assessments are quantitative in nature, and the process really involves the 4 steps, which is hazard identification, exposure assessment, dose response assessment, and risk characterization. So that's all great, but what does the epidemiologist really do with that information, or what are they trying to, get out of those 4 steps? And it's really these 7 or 8 questions, which is who, what, and where is the risk? Is it individual level, population level? What is the risk agent or hazard of concern? Is it physical, mental, chemical, biological? What is the origin of the risk assessment or hazard? Is there a point source? And then what are the routes of exposure? Mode of transmission, portal of entry, stuff like that. And then what is the physiological response to the risk agent exposure? So is it absorbed? Is it, distributed throughout the body, localized to a concentrated specific tissue? How's it metabolized or excreted? And then what are the pathophysiological changes? What amount of the agent is required to initiate those changes? And then what's the minimum time period for the agent to cause a toxic effect or signs and symptoms? So let's just take this nice little cold that's been going around, or the GI virus. Really just pick your virus right now, and I'm sure everyone's had it. You could ask yourself, all those same things, just as epidemiologists have asked themselves, all of these questions about the common cold. So they just apply them to more than, the common cold. So as I mentioned, really the rest of the chapter focused on an ecological risk assessment and workplace risk assessment, which I feel like weren't too far off of the initial questions asked. They were just, tailored a little bit more towards the workplace. And then the rest of the book was really about calculations and risk management. So I know one of the objectives was to talk about relative risk. So the relative risk provides information regarding the extent to which an individual with an exposure may experience the health condition. So when we're looking at a relative risk of 1, so 1.0, that indicates an identical risk is present among both the exposed and the non-exposed group. So to get the relative risk, you just take the incident rate among exposed and divide that from the incidence rate among the non-exposed, and that gives you your relative risk. To get the rate ratio, you would take your rate for primary interest groups and divide that by rate for comparison group. And odds ratio, that goes into depth a little bit more. It's really about case control studies that generate the data. So if you want to look into that a little bit more, it really goes off of this big table. It's table 9.1 on page 111 in our book. It's all the way at the bottom, and that'll tell you how to calculate the odds ratio. So I really like to bring it back to, what does this mean for us and how can we apply this to practice? Obviously, with a pandemic, it's easier to look at this from more of a, epidemiology standpoint. And, when we're having higher cases of things in our area, for example, we're having a really high outbreak of syphilis in our area, which is scary. But also just to know that we are using risk assessments every day. For example, we just had the Myriad reps come to our clinic, again, for women's health, but for MyRisk. And I feel like these two chapters kind of go hand in hand. We screen patients first to see if they are, a candidate for it. And then it's just a cheek swab. And then if they're identified as like a high risk population, we will, if the patient agrees to it, do a cheek swab and then test them for all those, genetic markers that would predispose them to any breast cancer, ovarian cancer, colon cancer, pancreatic cancer, you name it. And so it's really a screening, but then also trying to find if they're in that at-risk population. And we've had a couple positives come back, which is scary, but then we can, go from there and see, well, what is their risk of getting breast cancer with Lynch syndrome, and what should we be doing to mitigate that risk? So I'm sure everyone else uses it in clinic as a talking point. If one of you want to talk on how you guys are using risk assessments every day in clinic, or like the screening and diagnostic, that would be a good point to talk off of. So thanks for listening to my nasally voice, and I look forward to our discussion.